Great. Thanks everyone for being so patient and for coming. I was very excited to be invited here to speak to you all about a little bit about the work that I do. So my name is Dr. Corrine Metter. I'm a family physician and an addiction medicine specialist. I work out of Edmonton, Alberta, primarily in acute care. So I work at our inner city hospital there called the Royal Alex Hospital. And since 2014, I've been involved in launching what we call Inner City Health and Wellness Program, which is a consult service within the hospital to address substance use disorders for the patients who are admitted. So I'm going to talk a bit about why we do that and what that looks like at our site. So just disclosures, I don't have any interesting commercial disclosures. I do get a stipend for the work from our Health Authority, Alberta Health Services, that I do with our program and for some other work that I do. Most of the money I make is for my clinical work within the hospital. So I'm going to just take a step back and just talk a little bit about what a public health approach to substance use is, because this is really what we are trying to do with our team in the hospital. So Canada has always had these 4 pillars approach to drugs in Canada. Depending on, who the government is, they'll have different weights at different times. But it's enforcement, prevention, harm reduction, and treatment. So a public health approach is looking at the pieces that actually improve the health of the population. So that is these 3. So prevention, harm reduction, and treatment, and minimizing enforcement, because actually, as I'm going to have a few slides about, enforcement actually increases the harms to people. So our team really focuses mostly on harm reduction and treatment in acute care. Prevention is its own kind of different world, although you can always make the argument that by treating substance use disorders, you are preventing further substance use disorders in those people's families and children and friend group. So why do we try to minimize enforcement? Why is that not so important? So this was a news story back in 2015 about police finding fentanyl on the streets, making this massive seizures of thousands of dollars worth of illicit drugs. And I just found the first words out of the newscaster's mouth were just one of those just perfectly ironic sentences that just describes why enforcement doesn't really work in our drug crisis. So what he said, fentanyl use continues to go up in Alberta. Each year there are more seizures, but also more deaths. So really, the more drugs you pull off the street, it doesn't actually have the effect of keeping people alive at a population level. So this has kind of been where we spend most of our dollars in Canada. This is a little bit old data, but we don't really have anything updated. But back in 2009, 70% of that budget that went to addressing substance use, 70% of it went to enforcement, and really that hasn't changed all that much over time. And yesterday, just yesterday, there was the big story about Prime Minister Justin Trudeau signing on for again this enforcement war on drugs kind of approach to the drug trade. Very little you can see actually goes to research, prevention, treatment, and harm reduction. And in fact, at times in Canada, we haven't even been able to say harm reduction. That has been totally wiped out from our approach to drug use. We have more updated So, people who serve alcohol are trained to recognize intoxication and to stop serving at a certain point. We don't allow smoking in hospitals and airplanes and such anymore to reduce the risks of secondhand smoke. These are all examples of harm reduction, which we as a society support. And it's important, I include this slide because I think it's very important to recognize that even with our illegal drugs, so things like cocaine, marijuana, even though marijuana in a couple of weeks is not going to be illegal anymore, that there is still a range of harms. So most people who use drugs, whether that's cocaine, heroin, etc., are able to, we never see them in healthcare. They quit on their own, or they use very casually. And those are numbers like 80%. So 80% of people who have ever used cocaine in their life never develop an addiction to it. They never enter that kind of far end of that scale where it becomes that chronic dependence. So there is, even with our illegal drugs, there's a range of harms, that people experience. And even if you are dealing with that far range, so the harmful drug use, there's a range of harms even there. So if you look at, say, injection, so injecting drugs, so the most harmful end of the spectrum would be, reusing equipment, sharing equipment, lending it to other people. And of course, the safest would be to never inject at all. But there's a whole range of practices in between those two things. That relates to your injection use. So cleaning your equipment on your own, not a great idea, but better than not cleaning it, better than sharing it, better than lending it. The best again, not injecting, but slightly better than that, making sure that you have access to clean supplies all the time. So now we move into medicine and acute care and why we bring things like harm reduction and treatment there. And the first thing we have to recognize is that hospitals are actually high-risk environments for people who use drugs, which is hard for those of us when we work in acute care to hear that. We think that we are creating this environment where we are helping people and treating their illnesses, but in fact, we are creating a dangerous environment for people who use drugs, and I'll explain what that means. So this was a study out of BC, where they were looking at people and surveying people who use drugs, and they found that 44% of people who use drugs prior to hospitalization are going to continue while they're hospitalized. So it's not like you enter the doors of your hospital and magically your drug use or your problems go away. And when they do use drugs, it's in very unsafe ways, in unsafe locations. So in patient bathrooms, for example, with a locked door. So if you do have a problem, overdose, and it's hard for the medical staff to find you and get to you. And in fact, people can't practice their normal harm reduction strategies. So one of the things we teach people who inject opiates, we talk to them about, making sure there's other people around when you use, making sure that you go slow. Do a tester dose. Well, can you imagine if this was the advice we were giving them in hospital, right? They would be found, if someone would see them injecting, someone would see them using it, and they're then at risk of being discharged from the hospital and not having access to the medical care that they need. And when they further ask these patients, they do say that things like, needle syringe distribution in hospital, drug consumption sites would help engage them in care and keep them safe within that hospital setting. And people who inject drugs are among the most likely to be discharged from hospital against medical advice, which does lead to increased problems. So readmission rates, getting sicker. Now it's whatever you came in the first time is even worse. You're here longer and associated with increased morbidity and mortality. So, and again, it seems to be this hospital environment where we feel this need to enforce abstinence. So if we see you using drugs, then we're going to discharge you. You're not allowed to access care in hospital anymore, which leads to this increased leaving against medical advice. So just to summarize, so hospitals, risk environments, we have these abstinence-only policies. We don't treat people's pain and withdrawal appropriately. We don't address that. We don't consider that as part of, our medicine that we're going to offer them. Negative stereotypes for people who use drugs. So people cannot, practice their harm reduction. They get discharged, increased morbidity and mortality. And what does that look like in numbers? So patients who leave against medical advice are 12 times more likely to be readmitted within 14 days, doubles the risk of death. And they found that in this population of people who inject drugs, that this is a common phenomenon. About 25 to 30% will be discharged against medical advice. So whether that's them leaving on their own or them actually being discharged by the medical team. So what does that mean? So the hospital is a risky environment. So that means that we then have to make it safer for people. So that means harm reduction, treatment of substance use disorders should be integrated into acute care settings. So in Alberta, since 2013, we've had this level 1 policy statement from our health authority, Alberta Health Services, around harm reduction. And in fact, it's been rewritten recently. I'm not sure why, going through, all the chains so that it has to and processes before it's public. But what it says is that Alberta Health Services does support harm reduction as an important component in the continuum of care for people who use psychoactive substances. So that means that in Alberta, if you work in an Alberta Health Services facility, then you are going to be supportive of harm reduction. Your employer supports harm reduction. So we get people who say, well, it's against my values, it's against this. Then perhaps Alberta Health Services is not the organization that you should be working for, because this is supported within our organization. And this was an email that was sent out not that long ago from Dr. Verna Yu, who's our AHS president and CEO. Again, really reiterating that harm reduction is supported within Alberta Health Services. So this is the highest level of leadership within Alberta Health Services. And in fact, this email was about expanding that. So about expanding access to Narcan kits. So basically anybody who walks into anyone who walks into one of our hospitals or urgent care centers, whether they are a patient or a family member, they should be able to access a Narcan kit, an naloxone kit. That's what this email was about. So basically, if you're an urgent care center, you need to figure out a way that you're dispensing these kits. And the reality is that people do access care. So people in acute care who have substance use disorders, we talk a lot about inappropriate emergency visits, and yet if you don't have photo identification, where can you access care except the emergency department? If you don't have active provincial coverage for whatever reason, where else can you access care except the emergency department? It's open 24/7, you get care. So we talk about it being inappropriate, and yet for that person, that's their only option. And we've seen these rates of emergency department use consistently going up in Alberta. Even from the fourth quarter of 2017 to the first few months of 2018, the rate increased by 6.7%. So more and more, we are seeing acute care presentations for issues related to substance use. And what's even sadder, so this shows in the 30 days before someone had a fatal fentanyl overdose, over half of them accessed some sort of care, medical care. And that's very sad to me, that 56% of the people who died in the month prior to their fatal overdose, we had a chance to help them, and we had a chance to support them, and we missed the boat. And you can see these are emergency room visits, these are visits to your family medicine clinic, these are admissions to hospital, these are going to your pharmacy. So these are all points of access where we can make a difference in people's lives that we are just missing. And how have we done with treating substance use disorders in hospital? Really, really terribly. This is a study out of Boston, but we're always kicking ourselves that we didn't repeat this study in our own hospital before we launched our team. But I think any hospital in Alberta, probably here in Saskatchewan as well, would agree that this is kind of standard of treatment. So hospital in Boston, they were looking at patients who had been admitted to hospital with infective endocarditis that was related to drug use. And then going back and seeing what the discharge plan was, what happened during the hospitalization. Only 7.8% of the patients had some sort of plan in place at discharge for medication-assisted treatment, which is the gold standard treatment for opioid use disorder. So and if you further break down that number, it's even sadder. So one patient was started on methadone. One was given a phone number for a buprenorphine clinic. And the rest were already on treatment when they came into hospital. So all the hospital did was continue their care. Really, really terrible numbers. 0 of them received a naloxone kit on discharge. And when they looked back at this population, by the time they looked back, 20% or 26% had died since that hospitalization. And the mean age of death was 41. So these are young people who were dying. And again, when you're treated for infective endocarditis, for those that are not familiar, you're in hospital for about 6 weeks. So 6 weeks that we could have been helping these people onto treatment. And what do patients think about it? Again, this is from a population in Vancouver that they surveyed who were injection drug users and had been admitted to hospital in the last 2 years. Again, that harm reduction interventions, things like syringe exchange programs, supervised consumption services, offering methadone and buprenorphine are going to promote access and make that care better. So what we need to do is prioritize care retention over enforcing drug policies. And that's what people are asking for. So can this be done? Harm reduction and treatment of substance use disorders can very well be integrated into acute care settings. So this is what my team did. So back in 2013, our director, Dr. Catherine Dong, was able to secure grant funding through our Royal Alex Hospital Foundation. So this is charitable donations that she received a grant in order to launch this program. The mission statement has always been to provide patient-centered, evidence-based, and holistic care for our patients within the hospital with an active substance use disorder and/or those dealing with social inequity, so things like chronic homelessness. These are our team's guiding principles. I just like to go over the first one in a bit more detail. So the team will take its direction from the needs of the community that it serves. This has been key to our success. So this picture is a picture of our community advisory group. So these are people who live in Edmonton's inner city. They have experience or they are currently using drugs. And they have used healthcare services. So they have either been to the hospital, been admitted to the hospital, sought care here. So this was a group of people that we engaged from the very beginning, from when we received that grant, to ask them what they felt they needed and what would make that experience for other people in the inner city what would make that experience in hospital better, easier, more compassionate for them. We continue to meet with them every 3 months. We run by any new programs that we have. We get their feedback. Their feedback is invaluable. They are the ones who can tell us what works, what is not going to work, what needs to be done, what changes need to be made. And the other piece of that community is we've also engaged our community resources. So we're not working in this silo in the hospital. We're well connected with the community around us, the resources we spent. So when we hired our social worker and our nurse practitioner, they actually spent 6 weeks before we even launched the clinical service out in the community, meeting these different organizations, talking about our service, brokering those relationships so that we maintain very strong bonds with the community. And that's what the community told us they wanted. So they often were, helping patients, seeing patients, that then would go into hospital and they would describe it as it was like a black box. Like people would go in, they'd have no idea what was happening with that person. And then, 2-3 weeks later, they're discharged from hospital and they don't know what care this person now needs. So we are trying to change that. So this is what our team looks like. It's very large. So the hospital I work in, like I had said, it's our inner city hospital. It's 850 plus acute care beds. It's a massive hospital. It's one of the busiest and largest hospitals across Canada. So we need a large team, and we have an ever-growing team. So we have our clinical team, which is ARCH, which I'll talk about. We have physicians from every discipline. So we started with myself. I'm a family physician, Catherine Dong, who's an emergency medicine physician. We had a couple other family physicians, but since then we've hired psychiatrists. We have internal medicine specialists. We just hired an anesthetist. He just started this week. He is very keen, very excited. This is a very different practice than what he's used to. So it's a very interesting group. There's not many, clinical groups that will have physicians from all these different specialties. We have nurse practitioners, we have social workers, addiction counselors, peer support workers. So again, these are people with lived experience with drug use and homelessness. We have a pharmacist, we have nurses, and we very often have residents that we're training on our team. We also have an educational component to our team. We have a very strong, robust research team to be looking at what we're doing. There's a fly around here. A research team to be, continuing to inform the work that we do. And then we have our administrative team, which oversees all three arms. So the clinical arm is called ARCH, Addiction Recovery Community Health. So we launched that team July 14th, 2014. These are pictures from our launch. You can see it was a packed audience in our hospital's atrium. People were very eager to see this service rolled out. We had said we would start taking consults at noon. Dr. Dong, who's beside me in that picture there, was carrying the pager. It was going off, throughout the entire, our entire launch. People were very, very eager to have this team up and running. So our full team is available weekdays from 8 to 4. Actually, I should have updated the slide. Sorry. So our full team is available weekdays 8 to 4, but we also, our counselor and peer support worker are now available weekend and holidays as well. Physicians are available every day of the year from 8 a.m. to 9 p.m. And we accept consults from all the inpatient units as well as our emergency department. And we do maintain a small outpatient clinic where patients can be booked in directly from the emergency department because we're not a 24-hour service, so that we can see them and follow up the next day. So who are our patients that we're seeing? So this was 303 research participants back in the early days of our program, within the first year and a half. I comment on that because the number of people who inject drugs and who inject opioids specifically, like fentanyl, has definitely gone up. We've noticed that shift from when we first started. It was about half our patients struggled with some sort of injection use and half of them struggled with alcohol use disorders, but we've seen that ratio kind of shift a little bit. But 62% are male, mean age of 44, 42% are First Nations, so vast overrepresentation of our First Nations population. Drug use, 76% smoke cigarettes, over half have some sort of high-risk alcohol consumption where there's an alcohol use disorder or they're just drinking, beyond what we consider safe guidelines, and 61% use some sort of illicit drug. 45% use injection drugs, and 38% have had a non-fatal overdose in the past 6 months. And again, I would suspect that number has gone up since we did this first survey. You can see large numbers of hepatitis C, HIV, depression. 38% are homeless. Most of our patients fall at or below the poverty line. 20% or 21% have no medication coverage at all, and 30% have no form of photo identification, which again is a huge barrier to accessing healthcare anywhere other than acute care. And this is what our team offers. So when we first get consult on a patient, we have a standardized intake and assessment that we do. We make sure we take a full, drug use history, but also, we ask questions around their social stability, so housing, income, etc. We ask about mental health. We ask about physical health. And then what our team can offer is this range of basket of services. So we'll treat complicated intoxication and withdrawal syndromes. We start opioid agonist therapy, so things like methadone, buprenorphine, and more recently sustained release oral morphine, which is one of our newer treatments. We start pharmacotherapy for alcohol dependence, so there are good medications to help with cravings and such for alcohol. We dispense clean needles and other harm reduction supplies and naloxone kits. We have a managed alcohol program. So for patients who have severe alcohol use disorders, we will dispense alcohol to them in hospital in a controlled fashion to help them stay in hospital. We have our supervised consumption service. We have, the counselors on our team to do counseling, motivational interviewing, peer support, and we partner very closely with our psychiatry team in hospital as well. But the other half of this slide are things that are just as important as all those medical pieces, and that's our social pieces. So social determinants of health. So we consider these actual health issues as they should be. We know that housing, food insecurity, lack of stable income, these are things that affect people's health far more dramatically than their genetics do. So we address these and we consider these actual health issues that need to be addressed in an urgent way. So we'll look at housing, income support, photo identification, medication coverage. We do a host of health promotion activities, so screening for HIV, Hep C, and other sexually transmitted infections. We do immunizations. We've partnered with CDC to get immunizations on site to do like Hep B vaccinations and others. We'll do pap smears, and that was patients were asking for that. So our female patients who had not accessed care in a long time, they're well aware that they're behind in these screenings and they want to get these things done, and why not be opportunistic about it and do it while we have access to them. So we do pap smears, contraception counseling and prescribing, and then we also, as I talked about, have a strong relationship with our community because we know that we only have a short time with these people. So it is the community that then picks up those pieces and carries on for that long-term care. So I'll go through some of the things that we're offering. So I talked about the sterile injection supplies. So we're handing out thousands of needles. In fact, even more now that our supervised consumption site is up and running. And why do we do that? Because we know that this is one of our oldest, most studied, most reliable forms of harm reduction. So this was a policy out of the UN that just, really summarizes, and this is an old policy, like we don't have to keep, this 2004, we don't have to keep studying these things that we know work. So we know that, in countries where there are these harm reduction, where we provide sterile needles, they will have, decreases in HIV transmission rates, where countries that don't will have increases in HIV transmission rates. So this is well studied, well accepted. But we still hear objections to it, and we hear quite a few objections to it, even ongoing. So we hear people say having access to clean needles makes people less likely to quit using. But when you go back to the research, that's not actually what it shows. So this was a study out of Vancouver at a time when they were drastically increasing the number of needle exchange programs that they had in response to HIV rates and primarily IV stimulant use. So during this time where they were increasing the number of places where people could get clean needles, what they actually found was that the proportion of injection drug users reporting that they had stopped injection went up. So even though they had more access to needles, people were more likely to be quitting injecting. Interesting. So the opposite of what people will often argue with us. And then we hear this one a lot in our hospital as well. So we hear it from security all the time. Since you guys started, we're finding all these needles everywhere. Well, the thing is they weren't actually counting. They weren't paying attention to how many needles were around the site before. It's just, magically now, since we've opened our supervised consumption site, now, all of a sudden it's very important for security to be out there counting needles, yet they can't compare it to anything. What we know from research is that this is not true. So this was a study out of Baltimore where they very smartly, before they launched their needle exchange program, had teams of people out in the radius around counting needle and other drug debris. And then doing the same thing after that program had opened, and they found that it didn't actually change anything. And anecdotally from, communities where we've put in, even just drop boxes for people to dispose of needles, because people who inject drugs, they're not trying to hurt other people. They're not, they want to be safe. So if you do something simple, and this is something we've done at the hospital, so there's a gas station right close to our hospital, so, and that was always complaining about needle debris and stuff. So we put up a drop box, and, lo and behold, they were so surprised the first week. They're like, it was totally full. Yes, it is. People will use these things. So anecdotally, we actually think that some of these things decrease the number of drug-related debris that you see around. But it certainly doesn't increase it. So naloxone kits, so this is the antidote to opiate overdose. So we hand these out. The kits look very similar to this. Our team has been doing this since we launched in 2014. Alberta Health Services as a whole kind of picked it up, I believe, in late 2015. So we're dispensing hundreds of these kits. We get objections to that. So again, people will say having access to naloxone makes people feel like they can use more drugs. So because they know they have the antidote, they're going to be more unsafe and they're going to use more. But again, what does the research show? So these were 3 studies. One was done out of Edmonton. Edmonton was actually the first place across Canada that was dispensing naloxone kits quite a while ago. And they did study that phenomenon. And the other 2, one's from LA and one's from New York. And what they found actually is in the people who had received a Narcan kit, 6 months later, they were actually reporting less drug use. And this is an interesting phenomenon that probably should be studied more, but certainly it wasn't that people were feeling safer. They weren't reporting that they were feeling safer and using more drugs. We hear this objection. This is going back to like that life jacket argument, that allowing drug users to reverse an overdose without being admitted to hospital delays entry to drug treatment and allows people to continue using opiates without facing some of the negative consequences. So we hear some varieties of that all the time as well. But what does the research show? So again, this was a study out of New York, and what they found was that 74% of their participants called for help after administering naloxone to a friend or someone who had overdosed, which was about the same as if before. So whether they had Narcan with them or not, about 74% were calling 911 for help. So it didn't seem to affect whether they had naloxone on them or not. But I also, we can't always go to research. Sometimes I just have to, appeal to your common sense. So the goal of Narcan, the goal of putting naloxone in the hands of people who use drugs is to prevent them from dying. So I'll make the argument that if somebody dies from an overdose, they're even more unlikely to access addiction treatment than if we had brought them to hospital. I'm very good at what I do, but I'm not that good that if somebody dies from an overdose, I can help them and get them into treatment. So sometimes we just have to use common sense. We can't always go to research. So our managed alcohol program was one of our newer, since December 2016, we rolled it out. It wasn't one of the things that we were doing right off the bat, but it was in response to what we were seeing was that people who have very severe alcohol use disorders just cannot stay in hospital comfortably. They're leaving hospital to drink, they're discharging the cells, not coming back, or they're drinking non-beverage alcohol, what's available to them to things like hand sanitizer. So we developed this program. We've started, it's not everybody who comes into hospital. Most people, can go through that detox process and do want to go through that detox process. But for those who cannot, then we have alcohol. It's actually purchased by pharmacy. It's stored in our pharmacy. It's sent out by pharmacy, just like any other medication in these bottles like this. So it's the medicalized, protocolized thing that we have. Now, why do we do that? So we know that there's a fair amount of evidence from the community on this using managed alcohol. So these are all Canadian studies. And what they find, so these are, housing initiatives that tie managed alcohol to it. So if you live in one of these housing places, then they are going to dispense alcohol to you. And there's all sorts of benefits that they found. So decreased number of emergency visits, decreased police encounters, patients reporting less alcohol consumption, staff and clients are happier. They're engaging in healthcare, they're staying housed, improved quality of life, safe, again, fewer police contacts and incarcerations, fewer detox admissions, fewer hospital admissions. These are all very positive things that we wanted to bring to our acute care site. And in terms of the less alcohol consumption, for our patients that are coming in, again, these are people with severe alcohol use disorders who are drinking, usually a minimum of 26 ounces of hard liquor a day. We're able to stabilize them on, 5, sometimes 6 doses of alcohol a day. So drastically decreased amounts. But because we do it in that controlled way, people find that they're better able to control their use. I mean, that is in the end what a substance use disorder is, right? Is not being able to control their use. So we do that for them. So why did we want to use it in acute care? Like I said, we know that people with severe alcohol use disorders have higher rates of leaving against medical advice, higher rates of premature discharge, and greater risks of readmission. So that's what we've done. We're also very aggressive with starting people on opioid agonist treatment. So this is methadone, buprenorphine. So that is always one of the first things we'll offer people who come in with an opioid use disorder. Acute care is a great opportunity to engage them in care that way. And the reason we do that, so this is the National Opioid Use Guideline. So really, it was just published recently. It's very evidence-based, and it does inform what we do. And recognizing that the gold standard first-line treatment for an opioid use disorder should be methadone or buprenorphine or one of the alternatives. Now, a lot of people will talk about detox, so we need to detox these people. Why aren't you detoxing people who are addicted to things like fentanyl and heroin? And the reason that we don't, that is not first line, and in fact is discouraged, is because people do worse when they are detoxed. So this was a study looking at people who had entered a 30-day detox program. So even longer than most of our traditional detoxes in the community are, 7 to 10 days. So 30 days, they were medically detoxed from opiates, and then they looked at how these people did. And what they found was actually the people who successfully completed the detox were 4 times as likely to die from an overdose than those who had left treatment early. So the people who, again, I'll just say that again because it's so important. So the people who after a day or a week or whatever said this is not for me and left detox early were more likely to be alive than the people who successfully treated or completed detox. That's why that is not first line. That's why that is not recommended for people with opioid use disorders. We see this phenomena of people coming out of incarceration as well. So they've been forcibly detoxed in incarceration. Their risk of having a fatal overdose skyrockets on release because they relapse, they've lost their tolerance to the opiates, and that's when they are going to die. So we get objections to this as well, even though we've got, years and years of evidence behind using methadone and buprenorphine. So why aren't you taking them off methadone? They've stopped, you've fixed them, they're cured. And the reason being is because, again, they don't do as well. Discontinuing treatment results in relapse, increased risk of mortality. If you stop methadone, your risk of death is 2.4 times greater than it was when you were on treatment. So we don't, again, people get to choose how long they want to stay on methadone. People will choose to go off of it for a variety of reasons. We'll always support people in those and try to do that in a safe way. But we never are at, you've been on methadone for 2 years, it's time to come off of it. That's not an evidence-based approach. And I think, I always show this slide when I'm speaking to healthcare. We tend to get negative views of particularly methadone, increasingly of buprenorphine. But we need to remember that in healthcare, when working particularly in acute healthcare, we're only seeing the people who are not doing well on treatment. So that's like this iceberg analogy. So the iceberg that's above the top of the water is really easy to see. The people who are not doing well on methadone are really easy to see because they're in the emergency department, they're having overdoses, they're not doing well. But you have to trust, and particularly if you work in the community, you see this, that underneath that, much harder to see, is this much larger group of patients who are doing well. And in fact, you wouldn't even know that they're on methadone. They're working, they're raising their families, they are doing really well, but you cannot see them when you work in acute healthcare. So then supervised consumption services, this was our most recent innovation and probably our most controversial one, but we were working on it from, before we launched. So we applied for our Health Canada exemption to do this work in partnership with the 3 community sites in Edmonton. We received our exemption on October 17th, 2017. So our site is open for inpatients only, although we are exploring kind of expanding that to inpatients plus 1 visitor. So because a lot of people want to use with a friend or a partner. So when they find out that it's just for inpatients, then they will both leave. So we're looking at expanding that. But as of right now, it's for admitted inpatients only. It is open 24 hours a day, 7 days a week. It is staffed by nurses, RNs, LPNs, and every patient who accesses the service has access to our entire ARCH team. So social workers, counselors, peer support, etc. So we opened on April 2nd. I just include this slide just to show that we did have support from every level of government and within Alberta Health Services. So these are pictures from our launch date. So we had the Mayor of Edmonton there. We had our Provincial Minister of Health, Sarah Hoffman, there. Dr. Verna Yu, again, our AHS CEO and president, made a statement on it in support. So we've had support from every level to open this site. And why did we feel it was needed? Because we know we have lots of evidence on safe injection sites. Vancouver Insight has been open for years. We know that use of these sites is associated with decreased needle syringe sharing. So people are less likely to be sharing supplies. Women in particular have reported that they experience less violence, that they feel safer when they use these injection sites. And then we know that it does have an effect on overdose mortality. So this is, again, looking at Insight in Vancouver. And this study found that within this 500-meter radius of the facility where most of the people who use Insight live, 70% of the clients reside in that area, the overdose rate decreased by 35% after implementation. Elsewhere in Vancouver at the time, the rest of the city, the overdose rate decreased by only 9%. So Insight's been open for a long time, certainly predates any of the fentanyl issue that we've had. So overdose rates were decreasing naturally, but they did, compare it to the rest of Vancouver that was not accessing Insight, and in that area around Insight, the rates decreased more dramatically. So we hear lots of objections. So we hear you're just perpetuating drug use. You're not helping people quit. You're enabling their drug use. But actually what has been studied and what has been shown that having one of these safe injection sites is actually associated with increases in access, increases in treatment. So the Insight's opening was associated with a 30% increase in detoxification service use and increased rates of long-term addiction treatment, including initiating methadone and reduced injecting around the actual site. So actually more people accessed help because they were using that facility. And if you think about it, that makes sense. So if you're using that site, say 2-3 times a day, each of those is an opportunity for you to have contact with a healthcare provider, be it a nurse or peer support or whoever, helping you, engaging you, and talking to you about the treatment options and trying to figure out what you need to help. We hear this objection a lot: crime, lots of crime. But again, Insight studied this. They knew that they needed to justify their existence. So all of this was well studied. And what they found, they looked at crime rates in the neighborhood before and after implementation of Insight, and what they saw were no increases in drug trafficking, assaults, and robbery, and actually decline in vehicle break-in and thefts. So in most areas of crime, there was no increase associated with opening Insight, and in some areas, it actually decreased crime. And then we hear this a lot: I don't want my tax dollars supporting this. People are always very concerned about their tax dollars. I don't want my tax dollars supporting this. Well, the reality is that your tax dollars are already paying for drug use. So this was the cost effectiveness study out of Insight. And they found that if you just look at the one benefit of a safe injection site, if you just consider that one benefit of decreased needle sharing, the cost savings were, 20 million. So that these are huge cost savings. If you then look at other benefits, so things like decreasing overdose rates, et cetera, those benefits go up even more. So by investing in this, you are actually saving your system more. And you can think about that, even just preventing one new case of HIV, that treatment is incredibly expensive. By even just preventing that one new case, you're paying for your safe injection site. So it is very cost effective. So I want to just quickly go through some cases just to show some examples of the patients that we're seeing and how this approach of having these things in acute care can help. So this is a patient. She's 25 years old. We met her back in our early days in 2014. Severe opioid use disorder. This included IV heroin and IV Valium, which is a very, very dangerous combination. We were initially consulted in our clinic, so she'd been referred from the emergency department. So we saw her October 24th. And when I look back in the month prior to that first consult, she'd been in the emergency department 4 times with near fatal overdoses. So these were all very severe overdoses, all required naloxone, one required significant CPR and resuscitation. So at that first intervention with our nurse practitioner, she was pregnant at the time. She wanted to get connected with women's health options for an abortion. So we were able to do that. Talk to her about her drug use. She wasn't quite ready. She didn't really want to, engage in any treatment, but we did offer counseling, of course. We provided her with some harm reduction supplies. So then she's admitted to hospital in March of 2015. She came in with severe heroin withdrawal. Now, normally people don't get admitted for heroin withdrawal, but she'd been vomiting and had so much diarrhea that she had some electrolyte abnormalities that needed to be addressed. So if you look between that first outpatient consult we had and now this inpatient admission, she had one further emerge visit for an overdose. So what we did with her in hospital that time was we did stabilize her on a long-acting morphine product. She wasn't quite ready to start on methadone or buprenorphine, but we did stabilize her on morphine. We got her income support reinstated. We referred her for methadone care in the community, and she did actually follow up with that and was briefly on methadone at that time. We screened her for, STIs. We provided her again with harm reduction supplies, including a Narcan kit. And she did engage in care after hospitalization, but it was brief, and unfortunately she fell off, which is very common for people with substance use disorders, that there is that start, stop that we see. So she's back in the emergency department June 13th, 2015, after another overdose. So in this time between that inpatient consult and now this one, she'd had 3 further overdoses. So she was, 2-3 times a month, she was having an overdose that necessitated an emergency room presentation. So that third intervention in the emergency department, you could start to see some changes. So yes, she had gone off her methadone that she had been started on before, but she had already looked into where else could she get care and had booked herself an appointment with a primary health care clinic called the Bois-Macaulay Health Center to restart methadone and buprenorphine. It was 3 days away from this emerge visit. So it would have been very easy just to say, good, you've got that appointment, make sure you follow up with them. But she needed help, and she was so high risk, even between those 3 days, to now have a fatal overdose. So I connected with the clinic that day just to make sure that follow-up was secure. And I started her on buprenorphine in the emergency department and maintained her for the 3 days until that appointment. And of course, provided her with the Narcan kit. She had used the previous one, I think, on her boyfriend. So since that emerge visit back in June of 2015, this slide is up to date as of a couple months ago. It was the last time I checked in with her new family physician. She'd had one further emerge visit for an overdose, and that was within the first month of treatment. She's had no emergency room visits since June 25th, 2015. No further inpatient admissions. And this was a girl who's coming in every few weeks with an overdose. She did switch from buprenorphine to methadone. She preferred the methadone. She remains on methadone, like I said, as of 3 months ago, last time I talked to her doctor. And she continued to receive primary care at that same clinic. So things like contraception and treatment for her hepatitis C, she's accessing all those services. So this was a huge, huge change for this young woman. The next patient I like to talk about just because it demonstrates how important it is to address social determinants of health. So this patient, a little older, 53, COPD, she's on home oxygen, hepatitis C positive. She's been chronically homeless since she was a teenager. She uses alcohol and cocaine. When we first met her, she was also smoking and not so sure she wanted to quit any of those. So we were initially consulted in July of 2014 when she was admitted for a COPD exacerbation. In the year prior to that consult, she'd had 11 emerge visits, which resulted in 8 inpatient admissions. So kind of in the range of 1 a month, she was coming into hospital. And simple reason that she has severe COPD, she needs to be on oxygen, but when you're homeless, being on oxygen is very, very challenging. And in fact, most of the oxygen supply companies will not provide to people who are homeless unless they have a home. Shelters often turn these people away because of the risk if they're smoking and on oxygen, the fire risk. So very, very challenging. So we saw her, and then in the year prior, it's not like these problems are easy to solve, but in the year after that, until June 2015, she had another 20 emerge visits and 15 admissions, 12 consults to our team in total. We did lots of things with her. We helped her to attend addiction residential treatment 4 times. At times, we were able to find her interim housing. Briefly, she was housed in an independent apartment, but interestingly, she didn't like it. She felt very isolated and afraid living in an apartment by herself, and she would spend her nights at the shelter. So she very quickly gave up that apartment. We got her disability, so AISH approved, and so she was getting more money every month, screened her for diabetes, et cetera, et cetera. And then we had this admission from July 2nd to July 29th in 2015, where we were able to advocate to keep her in hospital until we could find secure housing on discharge. She was housed in a seniors lodge, a Métis Seniors Lodge on discharge. In the first 6 months since that admission, she had 1 further emerge visit and 1 inpatient admission, which is just a remarkable change. So, besides, her, what we've done for her, you can imagine the healthcare savings costs by decreasing her rates of presenting to acute care. We were still involved, helping her to maintain her housing, helping her with medications, income support, etc., trying to connect her with primary care and other mental health resources. Things started to change a little bit in 2016. You can see that from August 2016 to January 2017, things started to escalate a little bit again. So 7 emerge visits, 4 inpatient admissions, and then went back down. So it's pretty easy to see what happened there. She got evicted in June of 2016. So you can see this clear correlation between stable housing and not needing to access acute care so much. And then when it started to trickle down, again, pretty easy to figure out what happened, rehoused. So again, back in that seniors lodge, we were able to advocate to get her back. She'd had some issues with some other clients. Again, remember, this is a woman who hadn't been housed since she was, I think, 16 or 17 years old. So she was not used to living in an environment like that, and she did have some struggles, but rehoused since December 2016. So just to summarize, housed over a 10-month period, 3 emerge visits, 1 inpatient admission. Homeless, 6-month period, 8 emerge visits, 6 inpatient admissions. Housed again, 4 emerge visits, 0 inpatient admissions. So you can see a real change just related to her housing. And so what's our team doing now? We're always continuing to innovate. Education has been a big thing for us. We have yearly scientific symposiums. We do ground rounds. We do bedside teaching. We take residents. So we're continuing to increase our education to help make our hospital a better environment for people who use drugs. We doubled our team just September 4th. So just a few weeks ago, we expanded. We now have a dedicated emergency department team. We recognized that we were missing a lot of consults out of emerge and getting consulted on actually very few patients who were presenting. So we needed a second team just that lives in the emergency department and sees the patients as they are there. We are going to be launching what's called injectable opioid agonist treatment. So this is the next step in treating opioid use disorders. So for people who are not able to do well or not able to stabilize on things like methadone and buprenorphine. So this is providing them a safe injectable form of an opioid. So we have a target launch of October 9th for that. And we're continuing to explore better approaches to managing safe opioid use. So we've done some preliminary research that shows that patients who inject drugs are frequently diverting. So if you're prescribing them, an oral Dilaudid or an oral morphine, they're frequently diverting that to inject later on. So we're trying to figure out how best to minimize that and keep people safe. And that's it. So I think we've got a few minutes for questions. And we started a bit late, so thanks. Thank you. Any questions? I know I talk really fast. Oh, sorry. I wasn't looking over in the corner.
I do have one question. The safe consumption site in terms of acute care, is the site actually in the hospital?
Yeah. So the question was about where our site is located. Sorry. Actually, oh, sorry. Yeah. So there was a question about where our safe consumption site is located, and it's physically in the hospital. It was one of our old acute care units that had been closed for a long time. It was one of our old obstetrics units. Actually, our director, Catherine Dong, actually delivered all 3 of her children in that unit back in the day, and now it's our safe consumption site. So it is very easy to access for patients. Our hospital is very large. There's no way to get around that, but so they can walk down a pedway and access it right there. So it's easy not that we've ever had to call for code blue or even our pre-code team. We've never had to call them. We've never had to call security, but if we did need them, then it is easy to access. Yep. Mm-hmm. Yes. Yeah, so how it works is we identify the patients who would benefit from the service. We talk to them, we get informed consent, and then the medical team is notified that they are going to be using that site, and then they have access to that site. If we've not gone through that consent process, they can still use the site. The nurses in the safe consumption site will do the consent for them, but that information then will go back to the ward, and then it does recommend that they the medical team consult ARCH so that we can get involved in their care. Mm-hmm.
In terms of public opinion, here in Saskatchewan, we don't have great great support for safe consumption
Yeah.
sites, worse than other places actually when the cities of Regina and Saskatoon have been surveyed. How did you go about getting, obviously not everyone's on the side as you walk through all those myths that people still talk about. So how did you go about getting to the place where you could do some of this work?
Yeah, it's not an easy process for sure. And I wouldn't say we have huge support in the community. Our site in particular, the hospital site, the community, so people who live around the hospital don't object to it as much as the other community sites. And in fact, in Edmonton, the Chinese Business Association has launched a legal challenge against the Health Canada exemption. So more than likely nothing's going to come of that, but it's not that we've got huge support in the community either. We considered our community to be the hospital. So when we did do that community engagement piece, that meant going to, and every service within the hospital, whether that's security or maintenance and all the units and nursing and OT, PT, and having these discussions, having these presentations about what the evidence is. We hosted an open house. So before we launched our SCS, we hosted an open house within the hospital so people could walk through and ask us questions. We try to be as transparent as possible. We didn't want it to be, this secret thing that we were doing. So we've always been very upfront with people. And in general, our hospital, I would say, is supportive of it. But it has taken a lot to get there. And it's certainly not across the board support. In the end, though, sometimes when you're dealing with a crisis and you're working in healthcare, you have to make hard decisions, and not everybody's going to be on board. We certainly don't need the public's approval. We don't need, the community's approval to open any other type of healthcare facility. That is, a requirement of the federal government to get the community approval or to have done a community engagement piece. So it's not even necessarily that the community has to approve. You have to have done some sort of engagement. Sometimes you have to make hard decisions and recognize that not everybody's going to be on board. Yes.
I'll echo Dr. Reddy's comments. Thank you so much for coming. It's very interesting. I have a question about people who are on inpatient units who, as you noted, they do often leave AMA or discharged. Is there some best and promising practices that this hospital follows in terms of the steps that they take once they leave? Because we are concerned about their safety. They are high risk. But, often we hear things like people have the right to live at risk. And so do you guys enact your emergency preparedness, kind of those steps? Or is there a pathway that, physicians and nurses follow once they leave AMA?
Once they leave AMA?
Or if they've just gone missing?
So we discourage, and this is not across the province, but certainly at our site, we discourage using our Mental Health Act to force people to stay in hospital. We are working with another hospital right now where that's a little bit more common. So if you inject drugs and you need to be in hospital, they will actually force you to stay, like under the Mental Health Act, force you to stay in hospital. We don't agree with that practice. People, we have to respect their autonomy to make those decisions, and sometimes they are going to make decisions that we don't agree with, which is to leave and not seek care. We don't really have, I wouldn't say we've got any policies or practices in place when that does happen. We do try to keep them as safe as possible. We'll offer them outpatient follow-up, provide Narcan kits, harm reduction supplies, make sure they know where to access care in the community. So. Okay, great. Well, thanks for having me.